Hello, good morning everyone. Today's topic is atopic and contact dermatitis. Moving to the lecture. Dermatitis, which is an inflammatory response of the skin secondary to a number of exogenous and endogenous factors, which is reaction patterns in a number of skin disease, which is red, swollen, itchy, painful skin lesions, which is classified into exogenous, endogenous, and combined forms. Atopic dermatitis, which is a common type of dermatitis, chronic pruritic inflammatory skin disease with wide range of severity. Primary symptoms: pruritus, which means itch. Pathophysiology of AD: multifactorial conditions whose etiology is entirely understood. Genetic factors are there, disruption of skin barrier is there, abnormalities in immune response, and environmental factors also there. For the disruption skin barrier thing, you can find out the dry skin and increased IgE. Molecular base of skin barrier dysfunction: the filaggrin reduced level in appearance, and natural moisturizing factor also in reduced levels. Clinical findings: lesions typically being in an erythematous papules, which is erythematous plaques you can see, and weeping, rusting, scaling formations are there, and infection causing pustules. For the infantile phase, which you can see soon after the birth, and usually sparing the diaper area and the nose. Area of distribution: the lesion affect the antecubital and popliteal fossa, and localized to cheek, forehead, scalp, and extensive surface of the leg. However, they may occur any location of the body. Characteristic features, which is you can see erythematous, scaly, clustered patches, and plaques. Lignification is seldom seen in infancy. Adult face cirrhosis is prominent, which means dry skin is prominent, and lesions become more diffuse, cubital and popliteal fossa, and sometimes neck, face, and hand. As the features of the skin lesions, lignification may be present, and a brown macular ring around the neck is typical but not always present. Concerns of the skin infections, which is prone for infection, and Staphylococcus aureus is most common in AD lesions, which is atopic dermatitis, and can trigger the inflammations, appear as crust or pustules. Other possible infections like Eschema herpeticum, Coxsackie virus, then Mercurium contagiosum. Pulse of AD, which is usually not curative, approach should be depend upon the clinical presentation. So during the exacerbation time, we should provide the topical corticosteroids, calcineurin inhibitors, supportive measures like antihistamines and antibiotics. Then other medications, supportive medications like phototherapy also we can give in this case. For the remission time, we should ensure that daily bathing is needed. Emollients trigger the avoidance, then topical steroids in an intermediate phase. Okay, as a natural chronic atopic dermatitis is a chronic pruritic inflammatory skin disease with wide range of severity. The pathogenesis is genetic factors is there, skin barrier dysfunction is there, impaired immune response, and environmental factors. Diagnosis: itching, and early onset of this age onset, then age-wise distribution. It usually like come and goes. The treatment of AD is long-term use of emollients and gentle skincare. Contact dermatitis is a common inflammatory and non-infectious skin disease that occurs after direct or indirect contact with a substance that are harmful to the skin. The skin disease account for 30% of all occupational disease in an industrialized nations, of which 90% is due to contact dermatitis. May be subdivided into urethral contact dermatitis, allergic contact dermatitis, photocontact dermatitis, and protein contact dermatitis. For the urethral contact dermatitis, which is divided into soap, detergent, shampoo, solvents, cleaning agents, etc. And for the wet workers, those who are working in liquid or exposed to the liquid or in a glove factory. And for the urethral contact dermatitis, which cause direct injury to the skin in any person, if applied in a sufficient concentration for a sufficient amount of time with prior to sensitization or immunological memory. The spectrum ICD range from acute disease caused by single exposure to a severe irritant to chronic disease caused by repeated exposure to a mild irritant. The concentration of irritant and duration of exposure determine the severity of the disease in acute exposure. Photoirritant contact dermatitis, which is a specific type of irritant or toxic reaction that is mediated by exposure to UV radiation. Common cause include systemic agents and topical agents. ACD, which is caused by type 4 delayed hypersensitivity reaction in the skin and is initiated by low molecular weight chemicals and metal allergens penetrating the skin and combining the major histocompatibility complex on epidermal dendritis or Langerhans cells. The disease pathology is comprised into two initial and lectal phases. Clinical features: the contact dermatitis is characterized by the sign of erythema, vesicles, papules, scaling, fissure, hyperkeratosis, and symptoms of marked itch and sometimes pain will be there. Typically, contact dermatitis is induced by the exogenous factors and often it has origin and indirect or direct contact with irritant or allergic factors. As in this case, the lighter skin which you can see in the reddish appearance and the darker skin which you can see in the grayish appearance. So, clinical presentation of ACD varies generally, making allergic and irritant contact dermatitis difficult to distinguish clinically and histologically. Which is more acute and with marked itching will be present, and possibly which is lead to vascularization or blister formation or swelling. The skin, which include the redness, will be there, scaling, blister formations, papules, pustules, exudate, and excoriation. If in the case of chronic, you can find out the fissure, lichenification, and hyperkeratosis. Unlike the ICD, the borders of the lesions are poorly defined. Distribution often relate to the site of allergen exposure. The lesion can appear in other parts of the body that have not came in contact with the allergen. An airborne pattern of ACD may be seen in person to exposed to airborne allergen, often plants. Systemic contact dermatitis, which is an exposure to an allergen in a sensitized patient with a subsequent development of a cutaneous delayed hypersensitivity reaction. The clinical presentation of SCD can be complex with a high degree of variability. The simple presentation seen in localized recall reaction where the dermatitis occurs at the site of prior topical sensitization. Other end of the spectrum would be arthrodermic SAD. Baboon syndrome is there, which is erythema of buttocks and upper inner thighs, which was seen resembling the red rump of baboons. Mercury, nickel, ampicillin, which is first causative agent. So, SDRIFE, systemic drug-related intravenous and flexural exanthema, which is more precise term, which we by definition denote a specific cutaneous adverse drug reaction in which the previous cutaneous sensitization is not necessary condition. So, diagnostic criteria is there: exposure to a systemic administered drug either at the first or repeated dose, sharply demarcated erythema, if it is V-shaped or in the inguinal area or not, then involvement at least one other localization, symmetry of affected areas, and the absence of systemic signs. Contact urticaria is a transient wheel and flare reaction from direct with a chemical or protein agent. The lesion appears within a minute, an hour, and resolves within hours after exposure. Types: non-immunological contact urticaria, immunological CU, then contact urticaria of uncertain mechanism. Moving to immunological contact urticaria, which is the most common type of contact urticaria, remain localized and less severe than immunological contact urticaria. Not inhibited by the H1 antihistamines, oral or topical non-steroid anti-inflammatory medications are effective. It's a type 1 hypersensitive reaction mediated by allergen-specific immunoglobulin seen in previously exposed to the specific agent. Atopic individuals are particularly at risk. Contact urticaria from latex gloves is prototypical example of ICU. The food is the second most one, which you can see in the food, potato, carrot examples and etc. The additional causes like preservatives, fragrance, etc. The type of reaction may occur with substance that produce CU and generalized histamine type reaction that lacks direct or immunological basis of the reaction. It is most commonly caused by ammonium persulfate in bleaching the boosters. The typical has sudden onset of erythema, edema, severe pruritus, urticaria, and occasionally syncopate with wheezing. Protein contact dermatitis, which is a chronic eczema because of immediate hypersensitivity to the protein and not related to haptens. The repeated episode of contact urticaria can lead to protein contact dermatitis. For the diagnosis, any patient who presents with the schematous dermatitis should be regarded as possibly having ACD. Then, careful medical and environmental history we should take. History of the skin disease, is it atopy, the usage of personal care products like soap, shampoos, conditioner, deodorants, creams, hairstyling things, products, etc. The patient avocations or hobbies, then occupation. Investigations like a patch test, repeated open application test is there, and histocompatibility. Patch is the standard and most important diagnostic procedure for identifying the delayed type hypersensitivity cause of ACD. Then reproduce exposure to an allergen that must be performed in accordance with the international guidelines. Test the patient with AD suspected to have ACD. Those who do not respond to the treatment initially improve their exacerbation or present with the change of pattern dermatitis, not tested with acute generalized dermatitis or the extensive eczema on immunosuppressant medications. These are the two things which is not tested in. Side effects like skin reddening will be there, itch will be there, persistent reaction, fear of eczema, pigmentation change will be there, infections can be happen, and scarring. Patch test during first 20 to 30 minutes for after the application. If CU is considered 48 hours after application, the test are read 20 to 30 minutes after the removal of the patch to allow the erythema from the occluding pressure or striping of the tape or the chamber to resolve. Second, between 3 and 7 days after application. 30% of relevant allergens that were alert negative at 48-hour reading become positive at 96 hours. Type of the patches testing reading, a late reading 7 to 10 days after the patch test application. If there is a negative early reaction like metals that all the wings will be, then crescento and decrescento effect is there. False positive reaction, in this case an angry back symptom is there, which is false positive reaction adjacent to the large true positive reaction that induced contagious skin and inflammation and irritability. Underlying the mechanism are not fully understood, more likely to develop in patients with a longer duration of the primary dermatitis. And this in this case should be suspected in patient with more than 5 reactions in close proximity to each other. If suspected, repeat the PT with a greater separation of allergens, and ensure reactions are not clinically relevant because the false reaction positive reactions are not reproducible when the triggering allergens are removed. A pustular patch reaction is an irritant reaction and is common in atopic individuals, especially in response to metals such as nickel, copper, arsenic, and mercuric chloride. Repeated open application test, which is a suspect of allergens to the anticubital fossa twice daily for up 7 days and observing for the development of dermatitis up to 3 weeks. To replicate the reactivity of eyelid skin, road can also be performed on the back of the ear. Although the threshold concentration for a positive reaction for the rod per application was significantly lower than the threshold concentration of a positive. The accumulated rod dose was very simple to the PT patch test. Histocompatibility, which is similar to that observed in a schematic reaction. Treatment avoidance of identified allergens and irritant, consistent use of emollients and moisturizing agents, topical corticosteroids. Thank you guys for listening my lecture. Have a nice day.